You for inviting me to come here. I'm probably a bit different to most people because I absolutely love my job. And I have a huge privilege because I meet all sorts of really interesting people. And they share with me some of the most intimate things in their lives. And that's really a huge privilege to have. So what I'm going to try and do this evening is just give you a quick whiz through what our department does. And so if you've got any questions, shout out as I go along. If I'm not making it clear, yeah, I'm quite happy for you to dig in. Apparently this is as big as the screen will get, so apologies for that. So this is where we are. You recognise the building over there where the Trust headquarters are. That's where we're based. Now, we're an integrated sexual health clinic. You might say, well, what's an integrated sexual health clinic? We really grew up from two different clinics. My background's in contraception, menopause, well woman, mostly sort of female gynecology, GP sort of background. So I would mainly specialise in the top sort of section. The other half of the staff came from the GUM, the gender urinary medicine field. They tend to follow a much more hospital-based programme, much more physician-based, and they sort of specialised in sexually transmitted infections. All over the country we've been integrating because there's a heck of a lot of overlap. If somebody came to me and they got a bit of an infection, it was crackers for me to be able to diagnose it but not be able to treat it and have to send them to a separate clinic. And vice versa, somebody coming with an infection probably has contraception needs as well. So we have integrated. We still have people that are rather more specialists. So if somebody comes with something really complicated in GUM, it would be very much more sensible for me to refer them to the GUM consultant. And likewise, if she has someone with a complex contraception issue, she'll refer them to me. But the aim and the idea is for all our staff to be dual trained. So this is a little bit of a boasty bit because our trust has actually won the two tenders that we had. One we're responsible for Cheshire West and Chester. And we got that first, and there was always that worry that we might have that tender, but not actually be running our own tender as well. But we did actually win our own tender as well in Cheshire East, which is the area sort of outlined here. So the focus, now we've got the tender, we're really looking at two things. It's obviously far better to prevent things from happening in the first place. And so we're certainly going to look at primary prevention of infection, of pregnancies that were unplanned. But we're also looking, obviously, still to care for people who have got an unplanned pregnancy, who have contracted an STI. So we're looking at a dual approach there. The GOSH at the bottom is our new logo, Go Sexual Health. So it's for the Cheshire area. And there's a new website which is starting to be populated. It's not quite there yet, but it's getting there. And you'll find, I've put some handouts around for bits of information you might want to find out about, and there's a link to that, so you can find that. So, I go around quite a lot of places to do talks. I go around schools. And when I go around schools, I challenge them. I say, can you name me 10 methods of contraception? We have a bit of a competition. Sometimes it's one side against the other. And usually they can just about scrape up to 10 with a few rather strange ideas thrown in. I also go around WIs. Now, they tend to be a lot more sensible and I've been there and done it. And so WIs, I usually challenge for 12 methods. If I have medical students, I give that as an introduction, just to set them going, and challenge them to 14 methods. Sometimes they can get there, sometimes they can't. Now, I've got a slide that's got at least 20 methods. I was just wondering, would you be interested in raising to the challenge and seeing if you can get up to primary school? Actually, to be fair, it's secondary school. The primary schools, we don't do contraception. Anyone like to suggest some methods of contraception?
Say no.
Do you know what? That is often the one that's missed out, and it's the one, particularly at schools, that I'm most keen to say, because you sometimes need to give people permission to say no. On the telly, in the media, on Facebook, or their friends say what they're doing, and that's really sad that some of them don't feel that that's an option. Oh, well, he won't be my boyfriend anymore if I say no. We need to work with that. It's the most effective.
The pill,
The pill, fantastic.
not the oral one, the one you hold between your knees.
Well, that's a good one, yeah. Fairly effective. There are two types of pill actually. There's a combined pill that's got 2 hormones and a progesterone pill that's just got 1. So I'll give you 2 points for that one.
Male and female condom.
Mate, fantastic. Good, and another 2 points, excellent. So we're on to 4.
Coil.
Coil, you could probably sort of claim 2 for that, because there's 2 types of coil. There's a copper coil and there's a hormone coil. In a minute I'm going to show you some of these things. So yeah, we're up to 6 now, aren't we?
Implants.
Sorry?
Contraceptive implants.
Implants, fantastic. You may not have heard of them, but they're little implants, and I'm going to show you one in a minute. And if there's time in the questions, they end up actually fit one onto a model arm if you're interested. A little matchstick that sits under the arm. So that's the implant.
7. Caps, diaphragms and rings.
Woi, caps, diaphragms and rings, fantastic. Caps and diaphragms are things that fit over the cervix to stop sperm getting up. The ring actually is a hormone method, it's a method of giving a hormone as a contraceptive, and I'll show you that again in a minute.
Garlic.
Depends if you're French, I guess some people might think that was an aphrodisiac.
Or other similar substance.
Yeah. Injection, fantastic. Right, we're up to secondary school level. That's 10. Do you want me to whiz you through a few more?
Yeah.
Okay, so you've mentioned the combined pills, the rings and the patches, and they're all combined because they're combined estrogen and progesterone. I've got a little treasure box here. I mean, to be honest, I can pass you around pills, but they don't look terribly exciting. They just look like a pack of pills. But that's contraceptive ring. That releases hormone. You pop it into the vagina, leave it there for 3 weeks, take it out and throw it away and have a new one. So they do come ever so slightly lubricated. I've wiped all the lube off, so they're not sticky or nasty. What else have I got? I've got a patch. You're probably all familiar with patches that people use for providing pain relief and things. I'll pass it round. It's a sticky, transparent patch you pop on your bottom or your tummy or your legs or whatever, and it releases hormones. They're combined methods. We've got the progesterone-only method. Yeah, packed with pills. You've seen that. Injectables. Yeah, I'll show you an injection. Just, I thought it is worth sending it around because it's not very much injection. Some of that is space, so it's about 2/3 of the amount of the injection there. Okay, the implants one you may not be familiar with. Now, people get confused with this because they think it's a sort of a breast enhancer or something. It's actually supposed to be so that you feel it. So that's supposed to be what your arm feels like. The actual implant itself is a little white thing down there. It's like a little matchstick and it sits under the skin about there on your arm. And again, plastic releases the hormones. Then we've got the coils. I'll pass the 2 types around. I'll start with this. Actually, perhaps it might be easy if I keep the circuit going the same way, mightn't it? Some would end up with a whole bag of bits. This little model actually shows about the size of the inside of the uterus, the womb. It's actually quite small if you're not pregnant. And the coil fits there quite nicely. So I'm passing around one that's obviously got copper coils on it, and one that's got no copper on it, and that's the hormone one, and it's got a small amount of hormone on the sheath. They're actually white, but that's just to show it's a pretend one. Thank you. So those are real, that's the actual size that they are. Nobody mentioned emergency contraception. We try and call it emergency rather than morning after, because actually you can use emergency contraception tablets up to 5 days after having had sex. And that's really important. So people think it's morning after, oh, I've missed it. They haven't. It's up to 5 days. And actually we can use the copper coil, the one that we're passing around, as an emergency. In other words, we can put it in after you've had sex to reduce the risk of pregnancy too. So those are quite common. They're actually, you can buy them over the counter in chemists as well. You don't have to see a doctor for that. You do for the coil, obviously, because chemists are going to put it in for you. Condom. I'm not going to pass a male condom around, probably because most of you have seen one anyway, but also because there might be some with a latex allergy. This is a femidom. Now, I did have one in my bag that was completely removed of all the lube, and I can't find it. Someone pinched it. So this is one I have spent ages wiping it off. It's actually quite nice. Your hands get really quite soft after you use it, but it doesn't smell or anything. And this actually pops into the vagina. The inside ring holds it in place. This bit sits outside, so between your legs, and obviously the penis goes up there during sex. So this is the female condom. So it's quite an interesting change. Now you'll notice as you pass it around, it feels a bit rattling. People say, oh, it's like having sex in a crisp packet. It's not actually, because if you warm it up, if you wear it for a while beforehand, it does warm up and it's not quite as rattling. Diaphragms and caps. We're struggling. I'm quite a big fan of diaphragm and caps, and we fit a lot more in Macclesfield than a lot of places. But unfortunately, they're not particularly popular now, and they're not being made in great quantities. So caps we can't get hold of anymore. They're quite little things that fit over the cervix. This is a diaphragm, which sits. If I was wearing a diaphragm, it's actually in the plane of my body. You sort of assume it's at the top of the vagina and the penis goes like that. It doesn't actually. The penis sort of goes alongside it. That's why they're so big. Otherwise, you think, wow, how are you going to get that in? So that's a diaphragm. And this is one that's just come out. A lot of our staff haven't seen this yet. This is called a Kea. This is a new type of cross between a diaphragm and a cap. It's even got a little arrow on which shows you which way to put it in. They need to be used with spermicides. Now, nobody mentioned spermicides. They come as creams and jellies. And generally speaking, you would use a spermicide with something else. And certainly the diaphragms and caps, you do need to use spermicides. Sterilisation, yeah, we talked about that one, male and female. Nobody mentioned natural family planning. Now that's something we're really proud of in Macclesfield. There's only 117 natural family planning trainers in the country, and we have one of them here, one of our specialist nurses. Now you may have heard of the rhythm or the calendar method. It's working out when you're less likely to get pregnant, so you just have sex when you're less likely to get pregnant. But natural family planning is a lot more detailed than that. It involves getting to know your body, working out when you're most fertile. You do have to say no on the days when you're most fertile, because if you have sex when you're most fertile, you're going to get pregnant. But it is a way of not using hormones, not using barriers, and for some people, particularly for religious reasons, they feel more comfortable with that. But it involves examining yourself, it involves checking the mucus, which changes during your cycle. It involves checking the cervix, which goes softer or harder, checking the os, which is the hole in the cervix, because that changes during your cycle as well. So there's lots of things you do, and taking your temperature, which changes through a cycle. But that's something we do often in Macclesfield. Another one you didn't mention was lactational amenorrhea. That's basically for women to breastfeeding. If your baby's less than 6 months, you've had no bleeding at all, following birth, obviously there's bleeding then, but you've had no bleeding afterwards, and you're breastfeeding completely, in other words, you're not using any supplementary feeds, and you're breastfeeding at night as well as the day, then actually that's a jolly good method of contraception, so that's quite effective. But you have to fulfil all those requirements. Persona, I'm pretty certain no one in this room will have seen Persona. Certainly when I've taken it around, none of my medical students have ever seen one. This is really for gadget woman and man. It's a little computer. This is a placebo, so it doesn't actually work. But there's a little program inside it, and you type in dates of your periods, and various different things like that. And then each morning when you open it, if you come up, one of these little lights will flash. It'll either be a red light, which means not today, I'm afraid, because that's when you're fertile. It could be a green light, which says, actually, yes, you're unlikely to get pregnant if you have sex today. Or it might have an amber light, which says, actually, I need some more information. And that might be, it needs some more information about the last period or something like that. Or it might want to do a test. And there's a little tester here. There's obviously a box of them, so you're using a different one each time. And you wee over it, and then it measures a hormone. So you actually slot it into the machine and press a button, and then it will measure a hormone which will give it more information to know whether you're likely to be dangerous today or not. It's not quite the same as the ovulation predictors, which some people choose to try and definitely get pregnant. But it is quite good. It got a lot of bad press when it first came out. It cost about 60 quid, and these little boxes of things, you don't need to wee on a stick every day, but it can be 10, 12 days, and they cost about £12 for, I think it's 25. So it's not a cheap way of using contraception.
Not cheaper than having kids.
It's a lot cheaper than having kids. And the other thing you need to be aware of, if you're doing that and the little red light comes on, if you then go and use a condom, actually condoms aren't particularly effective, and so you can't blame the persona when you get pregnant. So if you obey by the rules and don't have sex when the fertile time's on, actually they're very good, but people tend to cheat, and that's where the accidents happen. Withdrawal, there's all sorts of local euphemisms for that, you know, going to Stoke and getting off at Congleton, and all sorts of trade analogies. But it basically means withdrawing before ejaculation. Not brilliantly effective, because once an erection happens, in the fluid at the end of the penis, there are very likely fertile sperm. So however controlled and brilliant you are at withdrawal, actually pregnancies can and do happen. I've put anal there. It's not really a method of contraception, but some people use it as a way of reducing the risk of pregnancy. A lot of people, particularly school children, say hysterectomy. Actually, it's a brilliant form of contraception, but it's absolutely not a reason to have hysterectomy. So there you go. There's a few methods of contraception. And I'd like to explain how we split them up a little bit. There are LARC methods, which are long-acting, reversible methods of contraception. And these coils, as you can see, last 5 to 10 years. The implant lasts 3 years. The injectable doesn't last quite so long. But obviously, these are great for the modern woman. They're absolutely brilliant for folk. We have a lot of air hostesses who work all sorts of weird and wonderful shifts. Nurses and medics working weird and wonderful shifts. Difficult to remember a pill every day. Something like this, absolutely brilliant. And then obviously these are the non-LARC methods, including wishful thinking, which I have to say works rubbish. Okay, so I could get you to do this quiz as well. Actually, I don't get very many takers in schools. My medical students are meant to be better. Sometimes can name a few, sometimes can't. So I'll show you a few. Chlamydia there. That's one of the commonest. We see a lot of chlamydia. Gonorrhea, that's been around for centuries. Herpes, I'm going to talk about some of these again in a little bit more detail in a moment. I put HPV, and it's written very small, it just says congenital warts. HPV virus is very common. There's over 100 types of HPV virus. There are 2 particular types which are strongly linked with cervical cancer, and so you may be aware that young girls, sort of 12, 13-year-olds, are being vaccinated against HPV with the intention that it reduces the risk of cervical cancer. I'm really delighted to be able to say that the government have finally changed the option, and they're changing it to a different vaccination which also protects against 2 other types which actually cause genital warts. Now, men and women get genital warts. We have dozens of people almost every day coming with genital warts. They can be a real nuisance. They're not dangerous, but they're a nuisance and people don't like them. And so this new vaccination is going to be protecting girls in generations to come. In Australia, where they've been using this for longer, it is actually reducing the incidence of genital warts. And I think that's fantastic. I'm disappointed that boys aren't being included, because boys get genital warts. There is a link with this type of virus with certain other cancers, esophageal cancers, and some others. We're starting to wonder whether there's a link with that. So I would love it if the boys were included in this vaccination, but they're not at the moment. You'll find a lot of sexual health doctors get their sons vaccinated. They can do that, but it's private. HIV, you'll all have heard of that. TB, you may not have heard of, called trichomoniasis. We do get a reasonable amount of that in Macclesfield. It causes a nasty, itchy discharge. Syphilis, you tend to think of that as Henry VIII and something that happened in the old days. Actually, we are getting syphilis. We get syphilis in Macclesfield. It's more common in men who have sex with men, and it's more common in people coming from, particularly from Eastern Europe. But we are seeing syphilis. I think Manchester is the second most common place for syphilis in the country after London. Possibly Brighton might be in there as well, but it's certainly quite a hot spot for syphilis. Chancroid, rarer, something tends to come from tropical countries, but we do see it very occasionally. Now the next three, molluscum, pubic lice and scabies, they often are sexually transmitted, but they're not necessarily. Pubic lice or crabs, same as nips really, but just lower down. But you can get that in other ways as well. Scabies, kids get scabies, infections in their fingers, but you can catch scabies as well sexually. Molluscum, again, something school children often get on their hands, but you can get genital molluscum. None of these are dangerous, but they're uncomfortable and itchy and not very nice to have. Hepatitis B and C, there are other ways of catching both of those. Hepatitis B you'll be familiar with people who inject drugs and that sort of thing. Hepatitis C, but both of those can be sexually transmitted. Talk a bit about that in a moment. PID is just a generic description. It's pelvic inflammatory disease, often caused by one of these organisms, and there are other bugs that can cause it as well. LGV, lymphogranuloma venereum, that has, you get buboes. It's again a fairly tropical disease, but we do see it occasionally, big buboes in the groin. And NSU is non-specific urethritis, often caused by chlamydia. It's something that men get, again, a whole range of organisms. But all those are things that you might come across or hear about. I've got a few leaflets. They're absolutely fab leaflets. There's some on contraception and some on various STIs as well. You're very welcome to help yourself. There's only one of each, but that handout I've given you gives you a link to where you can download all of these. So I'll put them there. Feel free to help yourself, but there are links on your handout. So at our clinic, we offer people screening for infections, treatment for them, and contact tracing. That's really important. There's no good in treating one of them per couple, and then they go back and have sex, and they get it again, or they transmit it onward to a new person. So contact tracing is a really important part of our work. We do offer hepatitis vaccination for people at risk, which is mainly men who have sex with men, and also sex workers and people who work in this, what we euphemistically call the sex film industry. So if you're a porn star, you obviously get extra protection because you like to have sex with more people. We do look after HIV positive men and women, ongoing care. We also provide something called PEPC, or post-exposure prophylaxis. So if you've had sex or you've been assaulted, or you've done something when you were drunk and you think you might have actually put yourself at extreme risk, or you've been on a stag do and you've crawled out of a brothel and you've no idea what's happened, if you get to us quick, then we can give you something that will much reduce your risk of contracting HIV. That's after the event. Okay, we do some work with genital skin conditions as well. And just to let you know, we welcome people from anywhere, any age, including young people. and you don't need a doctor's referral. Some people are referred. GPs who've got somebody with a difficult problem will get referred to us. All treatment's free, so all your antibiotics, all your contraceptives. We don't give out Persona, but apart from that, everything is free. It's completely confidential, so our notes can't be accessed by the gynae department or anybody else. They're completely separate from any of the hospital ones and completely separate from the GPs, so they're absolutely confidential. And we're certainly definitely non-judgmental. This again is my other little boast. Actually, this is a bit I'm really proud of because my big interest is medical education, and we're involved in training a lot, particularly our GPs. A lot of the GPs who you'll know will have been trained by us at some stage or another in contraception and sexual health, and we train the practice nurses as well. The obs and gynae trainees, quite a lot of them realise that actually having a good background in contraception is really useful. We're now starting to have medical students coming through our department as well. And my other role, I work part-time here, my other role is working for the faculty, which is part of the Royal College of Obs and Gynae in London, and I've been responsible for the diploma and writing the diploma, which is the qualification nationally, the doctors. And now I'm really proud to say nurses as well. We're one of the first Royal College faculties that's actually admitted nurses. So we're training nurses to the same standard as the doctors. And we've got some of the first nurses in the country to get that qualification. And actually, I've even got 2 of our nurses now who've taken our qualification to teach. And they on exactly the same merit as doctors, so they will be teaching GPs on exactly the same level. So I'm dead proud of our nurses and our department. So, I've got a few minutes left. I'm going to take you on a bit of a journey. This is what happens when you get through those doors. Many of you may have gone in and then taken a left because that's where the breast screening clinic is, the mammography and some of the gynae appointments there. So they swerve. But those doors, what's behind them? First of all, hopefully very welcoming reception. Reception is hugely important because often people coming through the door, they don't know what to expect, they're embarrassed, they feel awkward, who are they going to meet? So they first of all come to the reception, and we've got a big waiting room. We actually have a little waiting room if you really don't want to see anybody at all. You can stay at the desk. For instance, if you're a teacher and you just spotted one of your pupils there, or it might be the other way around, we have a little sort of room you can just pop yourself into. And we've got 7 clinical rooms. They're all much of a muchness, really. An examination couch. We have a team of people, and everybody is absolutely vital in the team. We've got receptionists, as I say, they're the first person the person meets. So they've got to be really completely open, unshockable, and welcoming, and reassuring. We have healthcare assistants. Now, healthcare assistants usually have little or no clinical training, but they are trained up within the department, and so some patients are only actually seen by a healthcare assistant. If you've come for a routine screen, which we'll talk about in a minute, and you haven't got any symptoms, we have nurses, and as I've explained, our nurses now, we're trying to ensure that they're dual trained in GUM and in contraception. We have health advisors. Those are the people in our department, they're actually nurses, but in some places other people will be health advisors. And they're the people that will do the contact tracing. They'll help you to inform the person that you may have infected or that may have infected you. They will do the confidential phone calls. They will send the texts. We have doctors, obviously. We have administrators. And that's essential because we've got these test results coming in. Nothing's done by name, so everything goes to the lab by numbers. So you've got to be really careful when you're checking results that you've got the right person linked with the right results. And we have management as well. They're the people that want to miss. I'm nothing to do with that. So this is just our back room. As you can see, lots of people there, busy. We do a lot on computer, checking results, following things up. So a hugely important group. So I mentioned about screening. A lot of people come with no symptoms at all and come for a checkup. And we really, really encourage this. The modern way now is if you're changing your partner, you both go for a sexual health screen before you start having sex, ideally before you start having sex. Quite often they come just after. But we're trying to make that normal. And we're trying to make that normal through all the age groups. Doesn't matter whether you're 20, 15, 40 or 70. We have people from all age groups because STIs are out there. We've had people from old people's homes with sexually transmitted infections. So everybody starting a new relationship actually should, for the benefit of themselves and their partner, check that they haven't got anything. And we check for four main things: chlamydia and gonorrhea, and you can have both of those without any symptoms, and HIV and syphilis. And as I said earlier, we might screen Hep B and Hep C for people high at risk. So for this screening, for men, you just need to pee in a pot. And it's a little pot, and we only need the first bit of your wee, because the infection lives in the wall of the in cells around the urethra, and so the very first bit you pee, so we only want that much in a pot. Now men, they're dead macho, they like to fill it to overflow. Look what I've done. No, we want the first centimetre of wee, because that's the bit where we're going to find the bugs if they're there. So they have to pee in a pot, you know, go to the loo, we're not going to watch or anything, and they have a blood sample taken. And that's an asymptomatic screen. So it's pretty low-key. Okay, it's a bit invasive, you've got a blood test, but it's no pushing and prodding with brushes and wires and things. For a woman, blood test for the hepatitis, the syphilis and HIV. But for a woman, the best test, you can do a wee, but wee tests aren't very sensitive for a woman. For a woman, we ask them to take their own swab. Now, quite often, if I'm in my consultation room, I'll just draw the curtain, say, bob behind the curtain and do it. Some of them prefer to go to the loo, that's fine. And basically, what they need to do, they've got a brush, and they need to pop that brush between the lips of the vulva and wipe the walls. We're not collecting the mucus, we want them to rub the walls 5 or 6 times right the way round. Only to that height, it's not right the way up. This is the clever bit now. This bottle's got liquid in. This is the bit that always goes, because you've got this swab, you've got your knickers around your feet, and you've got to open the lid, pop the swab in, there's a little black mark where it snaps off, and then put the lid back on. And that's what we ask them to do. So I'll pass it round. It's not a huge swab, and as I say, it doesn't go right up or anything, it's right around the entrance. And that will pick up chlamydia and gonorrhea. I put a comment there, notice window periods. Tests take a while to become positive. So chlamydia and gonorrhea, it takes 2 weeks before we can sometimes pick it up. So sometimes if you had sex last night and you're panicking, actually you need to come back again. We'll do it, but we need to come back again in 2 weeks. HIV and syphilis can be up to 3 months before the tests show positive. So screening, really important because some people don't know they've got it. We need to break the chain, we can treat early, and there are long-term issues. If you get pelvic infection, you can go on to lots of problems with fertility and chronic pain. It's usually the promise of chronic pain that galvanises the youngsters. They're not too thinking ahead of fertility, but if you tell them they might have chronic testicular pain, actually they might come and have a check. All the STIs can have an effect on pregnancy, and a lot of STIs can actually spread, and they have effects in the skin, eyes, neurological symptoms. You know, it's not just in the genitals where the problems occur. Got 5 minutes left, so I'm just going to whisk through. These are actually hypothetical, so if you can recognise somebody here, you can't, because these aren't real people. This is the sort of thing we do. Sarah comes in, she's 15, she's got a bit of a discharge down below. So, could be normal. At 15, she's probably just starting to ovulate, and actually when you ovulate, you produce a different sort of mucus, which is how you do the natural family planning. So it might just be normal. She might just need a bit of education. This is quite common to have girls that are being brought up by their dads, haven't actually got a woman they can talk to. So it might just be a bit of, this is normal, this is okay. It might easily be a non-sexually transmitted infection, for instance, thrush, candida, or something called bacterial vaginosis, which isn't an infection, but it's a misbalance of the bacteria that live in the vagina normally. It can cause symptoms if the balance is out of sync. or it could be an STI. I know she's 15, but it could be an STI. So obviously we need to take a really careful sexual history, and we've got to be sure that we're asking the right questions. We've got to make sure this girl, first of all, is safe. If she is having sex, how old is this person? Who is it? Is she safe? Can she say no? Is she being coerced? Is she being paid? Is anybody else watching? Are pictures being taken? All these questions we have to check. We have to check if we're going to give her contraception, that she fulfills what we call the Fraser guidelines. In other words, that she's competent to understand and accept what we're talking about. We would encourage her, under guilt competency, we would encourage her to speak to her parent, her guardian, an older sister. We won't make her, but we would strongly recommend, and we would work with her to do that. But if she says, no, I can't tell my mum, then we're not going to make her, particularly if it's in her best interest. If she's having sex, by definition, it is in her best interest to protect her as much as we can. But we're very keen to involve parents, obviously, if we can. We do discuss confidentiality. Now, we can't guarantee confidentiality, particularly to our youngsters, because if we think they're at risk, we will have to tell somebody. And we're also going to ask her about HPV vaccination. So she says, well, I had sex for the first time 3 weeks ago and again last night. So immediately, there's lots of things we now need to get involved with. Needs a pregnancy test, because by 3 weeks that could be positive. She needs emergency contraception for last night, ongoing contraception, protection against STIs in the future, screening for STIs, because we're over the window period here for 3 weeks ago. And we might need to examine her. If she's got symptoms, we might encourage her to be examined, because we need to know what's going on. So a lot there. This one's a quick one. Josie's 34. She just had a baby. She can't remember a pill. Wants something she can forget about. So we're going to look at a LARC method, aren't we? And then she says, well, actually, periods are quite heavy. So let's look at that Marinacol, which is the one with the hormone on, because that tends to make your periods very light. Maybe the injectable, which tends to, your periods tend to go away completely. But she might be married, she might have just had a baby, but we might need to ask her about STI screening. She might have a new partner. This is my last case. This is John, 57. He comes in because he's got a few small but very painful blisters on his penis. He's divorced and he's met a new partner recently. He had sex for the first time 3 days ago. Now, it's not a squeamish picture, but if you don't want to look, I'm just going to do a brief picture of what he's come with. Okay, so you can see the little blisters. And I'm going to move on to the next slide, so if you don't want to look, that's fine, you can look now. So we need to take a sexual history. Don't assume his partner's female just because he's been married. He might, well, this partner might be a male partner. I've talked about screening before sex with a new partner. So we need to take a bit of a medical history as well, because these blisters might be an STI, but they might actually be a drug reaction or all sorts of other things as well. Actually, that picture is almost definitely herpes, which is a viral infection related to cold sores. So he's got some immediate needs, pain relief. They don't look very big, jolly exquisitely painful. I've seen grown men in tears with herpes. They need treatment now to get it, the infection controlled. We can't cure herpes, but we can treat it. We can make the attacks shorter. We need to check whether he's peeing okay. If he's got some of those blisters right near his urethra, it's going to be agony to pee, and he might not be drinking, and he might be in complete retention of urine. And this happens for girls as well. Peeing in the bath is a clue. For a man, you can pee in a bucket. You need to have the penis in water. It dilutes it quicker, and it's one way. If you can't pee any other way, is to pee in the bath. We need to examine him. We need to take virology, find out what it is, and he needs some information about herpes. He also needs to screen because STIs usually come in groups. We need to warn him that in future, having had a herpes attack, he is liable to what we call asymptomatic shedding. He may actually be infectious even when he doesn't get the blisters. The blisters can recur, but he actually can be infectious at other times as well, and that needs a lot of getting your head around. We need to arrange to follow him up. He needs to be aware of the implications of any female partner, and the risk of having herpes when you're pregnant. It can affect the fetus. There's things we can do about that and prevent, but we need to know. So we do see quite a few pregnant women. We work with the gynae and the obs department with women with herpes. A lot of dealing with guilt, uncertainty, blame, who gave, we don't know, we can't tell them. And we need to give them advice about future STIs. So that just gives you some little picture of some of the sorts of things that come through our door and how one simple thing actually isn't and involves a whole lot more stuff. So I'm going to stop there because I've been told that you often have a lot of questions. I've got various bits and pieces I can show you if anybody's interested. I can pop the coil in one of those things for you and show how that works. I could fit an implant if you're interested. But first of all, I'll be most interested if you've got any questions.
Are your services 7 days a week? Can people access you anytime? Thinking like for emergency contraception?
Right. For emergency contraception, because there's always a pharmacist open, no, we're not open for that. We're not actually open for anything at the moment 7 days a week. We're 5 days a week. There's very few emergencies. If you've got a really painful attack of herpes, a GP should be able to deal with that as an emergency. Emergency contraception, because you've got up to 5 days, the pharmacist can usually organise that. Fitting a coil, often is quite a long time between sex and when you can fit the coil. The one that is an emergency is this Pepsi, this post-exposure, because you need to get there within hours really, and casualty, accident emergency here, can provide that if we're shut. But we do have clinics early in the morning and later in the evening, most other days of the week. If you're interested, again, I'll give you a link to where appointments are, where our clinics are, and I've got some sheets here which I'll pop here, so if any of you've got family members or anything that you think might be interested, list of the different clinics here.
Can I ask a question?
Hope not too difficult.
This is to do with the HPV vaccination.
Mm-hmm.
I know this has been around for about 7 years now.
Mm-hmm.
Here. Now, I do recall when it was being introduced, there was a significant amount of opposition to this in the US, especially from the right side of the political spectrum, including some presidential candidates who were really very vocal about this. In my view, the mistaken sort of argument that it's going to promote promiscuity. What has been the situation in this country regarding the uptake?
Well, the main argument in America was because they were going to include the type that stopped genital warts. And so they said, we're vaccinating our children not to get a sexually transmitted infection. This is horrible, this is wrong. Because we actually started with the one that was just for the types that were against cervical cancer, it was deemed slightly more acceptable. We haven't had a lot of problem with uptake. It's something that's done through schools and parents are advised and supported. My feeling is that one of the problems is following girls up. You know, if you've got the sort of girl who's not at school all the time, the nurse comes in sort of on 2 different occasions and you're ill that day, you're playing truant, something, people aren't being caught. And the anger that actually boys can't be given the injection as well. But yes, some people have said it's going to stop making people promiscuous. People say that about providing condoms to young people. Actually, if people are going to have sex, they're going to have sex, and if you want to do it and protect them as much as you can, then my feeling is that that's better than not protecting them. But the evidence shows that, for instance, emergency contraception, there was a big trial of giving people emergency contraception just in case. And they didn't actually tend to use it. In other words, they carried on using their ordinary method, even though they had this at the back of the cupboard just in case. Actually, it didn't make them take risks.
I'm just going quiet. I've heard that in some countries in Europe, they now all have developed
developed a range of self-tests or test kits.
They're available in this country.
Right, and I didn't know where we were on
Yeah.
that language.
And in fact, for chlamydia, one of the GOSH website will give people an option to write in for a chlamydia screening test kit that you can just do anonymously through. Well, you can't do it anonymously because you've got obviously they've got to get the result back to you, but you can give you a text number and you can do the tests that way. There are pretty much all sorts of tests, HIV and stuff like that, you can do through the post. Not desperately keen on that as a general idea because some of the places are not terribly reputable and taking a lot of money, and you need to be sure that they're doing a suitable test at the right time. If you do an HIV test and you don't realise that actually a negative test today might not mean that you haven't got it, the test is positive still. But yes, there's a lot of online stuff.
I suppose the reason for asking the question was we've developed our service here. Have we got plans to develop it some more based on some of the accessibility and immediacy of that testing?
Right, so you're thinking about tests that we might do by the patient as well. Yes, we have some tests that we can do straight away. We work close to the lab so that somebody, for instance, with gonorrhea, we can actually tell them within about half an hour, usually, if it's a good going on. So some immediate things. HIV, we generally send them on a 2-week turnaround, but if we've got somewhere we're particularly anxious about, particularly high risk, we can turn that around much quicker within the day. But yes, certainly the use of postage and on that sort of testing. Particularly, we're looking at the people that are high risk and difficult to get at.
So, Jenny, I remember when I was a teenager, there were all sorts of urban legends and myths that were taken as received wisdom. I was going to ask, with the internet being so accessible now, are teenagers not better sort of informed? Are they not?
Particularly about the STIs, there's some vitriolic websites. People come in completely terrified with absolutely the wrong idea, and there's some really dreadful things, and sometimes it makes our job a whole lot more difficult.
Yeah.
You're unpicking a whole lot of stuff.
Yeah, but it's brought them in though, hasn't it?
Sorry?
It's brought them in where they might not have come in.
Well, possibly, yes, there is that. Teenagers, I think, generally are getting better informed because there's more out there in the media as well about STIs and things. In fact, teenagers are better at coming in testing than the 40-somethings whose kids have just left home and gone to uni and the marriage is broken up and they're out starting new relationships. And of course, they've not thought about STIs for years and years, and they're the group that are actually quite high risk. But I've put some websites on the handout that are good ones. And certainly there's a super one on herpes, but there's some really dangerous ones. And people come in with all sorts of guilt and things. But yeah, it's quite common for people to come in, I think I've got X, Y, Z. And sometimes they have, often they haven't.
Yeah. You can get the balance wrong, can't you, sometimes, in putting the fear of God into people. I remember once, I think it was on Radio 1, they did a piece about HIV, and they interviewed a girl who, obviously it was all factual, but she'd lost her virginity to a long-term partner at the age of 18 or something like that, and got HIV from him.
Yeah.
And I just thought, listening to that will scare the hell out of a lot of people unnecessarily, because she did everything right, you know, apart from getting tested for HIV before.
Or using condoms, possibly.
Yeah.
I think we need to get the balance right. I think sometimes, I wonder whether we challenge people sometimes. It's really important that we're not judgmental, but I think sometimes people go away and do exactly the same. And come back and you sort of gonorrhea out, and then they go back to Thailand and sleep with a prostitute and come back. At some point, we need to actually challenge some behaviours, but that's not going to mean we're not going to treat people.
We're here tonight because we're interested in, and the publicity to get us here is quite straightforward. How do you actually promote your service? I mean, I'm too old to remember, but many years ago, if somebody felt that they were anxious about this, would they know where to go?
I have problems about when they get to the hospital finding us because there's no sign really up, and that is something I have brought up on numerous occasions. It's so discreet that occasionally I've seen people walking around sort of looking at the notes, can I help? You know, gum clinic. It's all right, I'll live there. It's that building there. I think things like that could be better. I think this Go Sexual Health is an aim to make it more available. We're going out, we're putting satellite clinics into areas where there's perceived greater need. I think using local radio. I think going into schools. I do go into schools. I think possibly the youngsters particularly realise that actually we're not going to bite their heads off and we're okay. I think that helps as well. As I say, I go around people like WIs, and I think it all starts at home, and if you've got an open relationships at home, you say, well, you know, are you using contraception? You know, go to the clinic, that sort of thing. I'm sure there's more we can do, and if people have ideas, I know we're looking at that.
Prevention is better than cure.
Oh,
In other words,
absolutely.
it would be absolutely marvellous if 50 people came to you and you said, we don't need us.
Yeah.
That sort of thing.
Yeah. Yeah.
I'm just,
But what we do need to focus on, we do a lot of worried well asymptomatic screens, and I'm very happy to do that. But actually what I really want to do is to focus on the people who aren't coming, who may actually have quite a high prevalence of problems that we could be treating. So it's those people that are difficult. So it's working with youth leaders, youth clubs, probation service, people like that who may have more access to people who wouldn't necessarily find their way to our clinic.
Do you actually have a lot of people coming?
Oh yeah, we quite often have to turn people away. It's a walk-in clinic and you can have appointments, and sometimes there are just so many people crowded around that we have to say, sorry, we're not going to get through you tonight, you're going to have to come back. So it's a busy clinic. Yeah.
You said that in the notes that you make it came separately from somebody's medical notes.
Yeah.
Away from you. Are there no circumstances where you'd have to share your
The
notes
only-
with another medical professional?
Well, sometimes we ask to, so if we're going to refer you back to the GP because there's something that needs sorting out. We diagnose diabetes, for instance, quite often because we do stick tests for things, and so that's the person would just say, we'll send you back, and so that's reasonable. We quite often refer to our gynecological colleagues for things, and obviously at that point we say, look, we're going to refer you by name, not by the number that we use. The only time that it would be disclosed is if there is if there's a legal requirement that we have to, which almost never happens, or if we're particularly concerned about it could be a vulnerable adult or a vulnerable child, you know, if we're concerned that someone's being abused, so we might need to share some stuff. But no, we really wouldn't, under normal, we're not going to write to your GP and say, guess what, this person's got gonorrhea and hasn't come back for a treatment. Actually, sometimes that is difficult, and we would love to treat you because we've done the test, we know you've got gonorrhea and you haven't answered our text. But we're not going to go into your GP and say, hey look.
So in a way, it's quite a difficult job, isn't it?
It's hugely emotionally
Yeah.
and spiritually quite challenging.
Very
actually.
wearing.
It can be. It's really wonderful because you meet a lot of really interesting people. It can be completely exasperating
Yeah.
and very frustrating. And it
Absolutely.
sometimes makes me angry as well.
Yeah.
You have to be professional and you know, you have to accept that you are you and you have your own emotions and thoughts, and you just have to be non-judgmental and you know, treat everybody as you would hope to be treated. So yeah, it has its ups and downs, I'll be honest with you.